meeting. So I'm just going to introduce our illustrious speakers. I just learned that Doris, our first speakers, Doris Hincapie from Halton Catholic District School Board, is actually part of a theater group, which is great for her mental health. So that's a great intro. She's a psychologist with a master's degree in education and a postgraduate certificate in international development. Doris is trained in several counseling techniques with certificates from the U of T and a member of the Canadian Counseling and Psychotherapy Association. Doris has worked as a community psychologist and as a settlement specialist with newcomer families, providing a variety of one-on-one counseling, group presentations, and support groups throughout the GTA. In her most recent role as newcomer support officer with the Halton Catholic District School Board, she uses a strength-based approach and provides short-term counseling services for people facing various life challenges. And I'll also say that she's leading the network of crisis workers in settlement in Peel and Halton. So it's a great community of practice. So I'm going to follow with the other intros as we go. So I'm going to turn the next 10 minutes over to Doris to share some perspectives from her work and that network. Thanks so much, Doris. I think you're on mute.
Yes, thank you, Jessica, and thank you all of you for being in this meeting. I have some faces that are familiar to me anyways, and I'm happy to see you all. I'm going to share my presentation, and I wanted to be a little bit humble to all of you because I'm talking here on behalf of all my colleagues, crisis workers or short-term counselors, and I hope I can express all the work that we have during this pandemic. So this is my presentation. I hope that all of you can see it. Okay, let me put it in. All right. So we call, in general, our name is short-term counseling, right? But we have from the past, at the beginning of this title of our role it was crisis counseling, and it's being changed by the immigration board for the short-term counseling. So this is me. This is what I do. I work at the Halton Catholic District School Board, and my colleagues work in different organizations that work with newcomers and refugees from Peel and Halton. So all the organizations that work in Peel and Halton are part of this network of short-term counselors. So it's a big group, and we started with this group at the beginning of the pandemic. So previously to the pandemic, we usually have maybe twice a year these meetings. So we identified that maybe it's important to get together and support each other and see how we can work for our clients and offer the best services and unified efforts. So we are not clinicians, we are short-term counselors. And even though I have some colleagues who are psychotherapists, who have more experience in that part, we are not entitled to provide psychotherapy, right? However, we ended up doing it because there is a lot of services, waiting list services for our clients, and we just want to do our best for them and help them to support them during those crises or maybe difficult situations that are living. So that's why I said that we notice, we listen, we respond and connect, and we refer our clients to community resources. Our role, as I was telling you, I know there is a lot of wording here, but our role is to support, is a support services. And our intervention is when they are in need, in an urgent need. So many of my colleagues are doing also, besides the mental health support, they are working in housing as well. They are helping them to find financial resources because this is part of the crisis. So we assist the client in the resolution of those difficult situations that will facilitate them the pathway, the settlement pathway, or achieve this successful adaptation here in Canada. Or maybe I know that is quite ambitious, but we support them to achieve this wellness, or support them to find the tools and strategies that will help them to achieve what they really want to achieve in here, their goals. So our support services beside the counseling was also focused during this pandemic and continue being, and it was before as well. We do mental health promotion presentations in different topics, and we work together with the community as well, with the schools in my case. Not all crisis, or not all short-term counselors in Peel and Halton work in the schools. They work also in organizations, newcomer organizations, so not related with the schools, like in my case. We provide the short-term counseling and is supporting the adaptation process. And we do referrals to specific language counseling. And that was a very good, should I say, silver lining of working together, all of us, because in my case, I speak Spanish, but I also speak English, even though I have accent, it doesn't matter. But we also refer clients to our colleagues, and we have richness in languages. We have Chinese languages like Mandarin. We have Cantonese as well. We have Punjabi, Urdu, Arabic. We have so many languages, even Russian as well. So in French. So there is not a limitation if one of my clients is in need or have this language limitation. I can refer this client to one of my colleagues. So that was one of the good process and learning process that we achieved during this pandemic. And we also refer to different other organizations that can help better our clients. And this is the model somehow, it's still in process. So our role as a short-term counseling, our network, we work in both ways. It's a kind of holistic way. We call, in my case, I work with the Swiss worker. Swiss is a settlement worker in the school, and we have in the public board and in the Catholic board, and we have meetings, not regularly, but we work with them. And the settlement workers, we have in all organizations, settlement workers, the teachers who are the ESL teachers, and the community in general. We have some partnerships with different communities as well. So the idea is that all of us, especially this part in here, the settlement, the teachers, the community in general, they are the eyes, the ears, and the heart of the newcomer families, because they are the one who notice. The first one who noticed. They are the ones who heard and who connect them with us as well. So I put this red arrow because sometimes when I'm working with a client, I know that a settlement worker will provide better services, and I provide that service in mental health as well. So the idea is to provide this. Many of the needs of our clients are related with the settlement process. So we work together. So that's why, even though I sound like a little bit ambitious, I think that we are the eyes, the ears, and the hearts of our newcomer families, because we notice when something is wrong or when something is not working well with somebody, and we suggest them, would you like something? Would you like for me to refer you to someone? And when we do the presentations, we know that there are a lot of taboos or a lot of wrong ideas about mental health from different cultural backgrounds, but we try to minimize those things. And educating people is being a big achievement as well, for the people to reach out to us as well. So this is somehow the model that we use. And the process, I know this too, Lord, the process that we use to refer our clients is first, let's say I have a client that doesn't speak English very well. Let's say speak Arabic. And first I talk with the teacher, if the teacher is the one referring me that client or that family, and see how we can support better that client. And if the client doesn't matter, if he doesn't matter or she doesn't matter, that we can have an interpreter, we do. But if the client feels better with myself referring to one of my colleagues who speaks Arabic, so I refer to that one. And this is the process that we use. And then we do follow-ups and talk between our partner or the person that I refer this client to see how this client is doing, how we continue working together. I don't do just refer the client and that's it. I need to know how things are going on and how we can support better. So that's the idea, to unify efforts. And if the client goes to the other organization, I know it's good because it increased the possibilities as well for both organizations as well, because we all have to, you know, we need to do reporting as well. So, but we don't find that we shouldn't report, let's say, a client in my system if I'm not seeing that client. But if someone in the network that we have is seeing that client, that person will report that client as well. So this is the way we do, and it's working, and it's being successful as well for our clients, which is our main purpose. During this pandemic, what we saw was increasing, or the trend, should I say, the prevalence is that we have refugees. In that case, we have many refugees in Peel and in Halton, and majority of those refugees are coming from unstable countries, from war as well, and they are already traumatized. So this, and then come here to Canada, and then we are in lockdown, we are isolated. This ended up adding more risk for this population. I don't want to use extreme words, but it's what's happening. That increased the domestic violence as well. That increased the uncertainty. Some people were unable to find a job. Some people lose their job. And also they have to face the new roles in the family. Maybe the woman find a job, but the man at that home is not being able to find a job. These changes of the role is affecting as well that family system, and it increased as well the risk of mental health problems in both sides. Well, as I said before, the domestic family, that was very persistent in the for the refugees cases that we have, and also we saw it as well with permanent residents. And I know I have some Canadian citizens as well. So that was a prevalent in general, but was more noticeable with the refugees, okay? What we do always, and continue doing it, is identifying social needs. And we wanted to link these clients to resources. So at the beginning, and still it was a good practice, we find out that sending weekly emails. And at the beginning, we wanted to let them know that we are there for them and that we were still working and that we can connect by phone or by email, or even some people were using Zoom or the Teams. So that was the important issue that we learned during this pandemic. And as I said, some of my colleagues are not only focused in the mental health area, but they are trying to find income supports, online training, linking them to community service, finding housing, shelter. That part is a big piece of the job for providing some relax for these people who are in need. We collaborate, we work collaboratively with other settlement organizations or with other community organizations, with many. We have somehow unofficial partnerships with CMHA, with YMCA, with many community other services, let's say with Salvation Army, with the food banks, all those organizations that provide services have been a very good support to work in teams and to work more holistically. And we use all the platforms, and that was a big learning individually or professionally for all of us and also for everyone. We are also tired of these platforms, but it's been it's been a bless, I can say, but it's nothing is better than being in person, okay? And then we connect clients with virtual support groups, especially the seniors group. We have, in all our organizations, we have different seniors group, let's say from the Spanish community, Arabic community, Indian, Pakistani, all of them. We have a lot of in Chinese, and we provide those referrals to those groups, and it's been very good experience working online. It's a very challenge, but they were learning to use those platforms, their phone better, because everyone has a phone, and they connect and they feel good. For those programs, those programs were more focused in arts, in exercise, in recreation, and having some fun, and that was a good experience. So those, I'm not going to talk about all those services, but we did a collection with my network of support counselors, and we collect a big amount of support that we use, and we refer clients when they really need more specialized services. Those are all the services. I'm not asking you to read all of them, but I can share with you. And okay, that's all. Thank you so much. I think that I didn't spend that much time.
Perfect. Thank you so much, Doris. Yeah, it's wonderful to have the perspective from the settlement short-term counselors and that network that's formed. So thank you so much. I see, Hala, do you have a quick question? And then
yes, actually, it's a quick question. Yeah, Doris, thank you so much for this short, clear, and concise presentation. Thank you so much. So I wonder, in your experience, do you find that refer your client to a language specific support? Is it more effective than dealing with your client with an interpreter in the middle?
You know, it depends. We find it very successful, because in the follow-ups we did after that, the client felt more comfortable speaking in their own language than having an interpreter. And it was more, like, I will say that was more organic. Like, you feel better when you can speak in your own language, especially when you're talking about issues that involve your wellness, your mental health, your emotions.
Yes.
However, I have cases in where I use, I shouldn't say I used, like in where my settlement worker that speaks Arabic was with me, and she was interpreter. She was doing the interpretation, and the client felt good, and I provide a little bit training as well to my settlement worker that all the things that we talk has to be in our office or in our setting in the screen, but we shouldn't talk about those things out and some training about what she can do when something is bothering her or something she feels shocked when the client was telling something related with abuse or something like that. Yeah. It also, I forgot to put that one. We all our short-term counselors provide training to our settlement workers, our colleagues, settlement workers and teachers. I don't know how come I forgot that, but that was something that we did as well. Yeah. It's been a huge and beautiful experience as well, very challenging, but very positive as well. I hope that I answered your question.
Yes, you did. Thank you so much.
Thank you.
Perfect. So there's some questions in the chat box, Doris, that you can follow up maybe at the end, or feel free to, we can follow up with email or in the chat itself.
Okay, thank you.
Thanks so much. Really, really appreciate your presentation. I'm going to move to CMHA Peel Deferent. We have Laura Smenderovac. Did I get that right? Okay, sorry about that.
Don't worry about
okay, I was trying to practice. She's a social worker and is working right now as team lead with a 24/7 crisis support Peel Dufferin team. And prior to being team lead, she was a crisis worker herself for 4 years, and previously a case manager with the mental health and justice team through CMHA. So welcome, Laura, and she'll be sharing on pathways for crisis support. Thanks so much.
Thanks. Okay, so I will share my screen. Just give me a second. Okay. I don't know how to work things, so give me. Because I don't want to stop the video, but.
Oh, I think just on the bottom. Oh, I think at the that's the button. There you go.
There we go. See, I don't know how to work technology, so that's my bad. Right. So I'm one of the clinical team leads for 24/7 crisis support Peel Dufferin. I know it says Peel here, but we're Peel and Dufferin. So we serve everywhere from Mississauga all the way to Melanchthon, if anyone's familiar with Dufferin. So it's a huge region our program specifically supports. But for case management supports and counseling supports, CMHA Peel Dufferin only serves Dufferin in Brampton Caledon. So Mississauga is excluded. CMHA Mississauga Halton will take over that stuff. Okay, so just a little bit about us. Our program launched in March of 2015. We're the largest program in our organization. So we have about 40 staff total as just the crisis team. We launched our program into Dufferin in 2020, and our mobile crisis rapid response team also launched like January of 2020. I'll explain a little bit more about the roles after. And we are going to be launching, so it's been pushed from June 20th, but our clinician crisis rapid response team. But that will be coming in the next couple of months. Okay. So the scope of what we do is the crisis line specifically. We have a 24-hour crisis line. It's available to all residents of Peel and Dufferin, so people can call whenever they need. We support care providers, family, community members. Everyone is welcome to call. It doesn't necessarily just have to be the client. And it doesn't have to be that person specifically in crisis at that moment. So if a family member, even a community worker has concerns and they're not sure next steps on what to do, they can always consult with us. We also do complete in-person visits. So we do that through Brampton, Mississauga, Malton, Caledon, and Dufferin County. So we don't reach into Etobicoke. And we do go to basically the very, very border of Etobicoke and Mississauga. Okay, so our goal is to enable people who are in crisis or have serious mental health or addictions concerns to remain safely in their own environment. So our goal is to keep people out of hospital or with the reduced police contact if possible. And we are really working towards having more accessible and culturally sensitive programs and services. So a little bit about our team. So again, our line's 24/7, so we're via phone. We're all registered health professionals, so social workers, occupational therapists, and nurses. We're open year-round, including holidays. So our mobile outreach, so we do visit people face-to-face, but it is dependent on our availability and prioritization of who needs to be seen. So you might call, someone might need to be seen, but we might have a higher risk person that we have to prioritize. And same with their rapid response. They might be on a call or they might not be available at that moment. And we are partnered with Punjabi Community Health Services, and we are now partnered with Roots to better provide culturally appropriate services for clients. So our Punjabi Community Health Services staff have been working with us for almost a year at this point, and so they are helping answer our live calls and doing outgoing calls, specifically to reach the Southeast Asian community and help better connect them to supports, because someone that calls into the crisis line can be connected to appropriate supports and be able to speak their own language. Okay, so again, going into language needs, so we have a large team that speaks various languages. So we do try to deliver languages in the person's preferred language. And if we don't have a worker that speaks that language that's available on that day or in the next little while, we will use interpretation services. So if someone does call in the line and, for example, speaks Farsi and our Farsi worker is off, we will arrange immediate telephone support via a translator over the line. And we do arrange in-person interpretation as needed too. So we use MCIS and Rio for assistance where needed, but it's actually estimated we can speak about 17 different languages on our team. So we have Punjabi, Hindi, Malayalam, Farsi, Tamil, Arabic, Serbo-Croatian, Bosnian, Vietnamese, so we have quite a few. And so we are trying to really find more applicants that do suit the community's needs. Okay, and so this is the regions we support to give people a visualization of how large of an geographical area we support. And we support 3 police services, so Dufferin OPP, Caledon OPP, and Peel Regional Police. So that excludes us from York and Toronto. We do get a question of why police are part of our program and they're integrated into our program. And it's usually because they're attending a lot of frontline things where we're not being called or alerted to something. And they are actually a first point of contact for a lot of people because a lot of people don't know about crisis lines, so they do call 911 instead. And you might not call the right crisis line for your region, so it can get confusing. And usually people end up calling 911. So we have our police partners who are specially trained and apply for their positions, and they bring us in as mental health clinicians because of our expertise, and we assist with calls and help even just give information. So we do have officers even call into our line. And so the big reason is mostly because police have authority to take someone to hospital if they don't want to go, and so against their will, they temporarily can suspend their rights. As a clinician, I cannot force someone to. Okay, so we attend 5 hospitals. So we support Credit Valley, Mississauga General Hospital, Brampton Civic Hospital, Etobicoke General Hospital, and Headwaters Hospital. So those are the hospitals we typically will take our clients to if they need to go, and we do have working relationships with them. So how we connect with people. So we either connect by phone, so we can phone people for telephone support, or live incoming calls, and introducing our services, so cold calling people that were involved in police occurrences, or if someone refers them to our services and they're not sure of who we are or we don't have any previous contact, we'll do a cold call to introduce who we are and see if they're interested. Or we do in person, so our COAST model, again, I'll explain all these acronyms, our non-police model, our rapid response, and our CSERT. So for the calls, our crisis line is our main point. So crisis workers will respond to crisis calls 24 hours, 7 days a week over the phones. So they also complete outgoing calls along with taking incoming calls, and they also do all the referrals for our clients. The crisis support worker will assess information regarding the person's current crisis, and they'll use that information to triage the most appropriate response based on that call. So you might call in and ask, I need this person to be seen in person. Our crisis worker will work with the information to determine if it's appropriate and if there's capacity and so forth. So basically they'll determine if we need to reach out to the person first, if we should be seeing them face-to-face right away, or if we do need to call 911. Okay, so COAST is our crisis outreach and support team, and we have 2 units of this. So it's a specially trained plainclothes police officer who basically we call them our taxi drivers at the end of the day, but they are paired with a crisis worker, and we meet with people at the place they're choosing to complete a mental status exam. So basically a full crisis assessment to see what's going on, where they are, what they might need. And we always do our risk assessments to assess for suicidal risk, homicidal risk, or any other concerns about their ability to really care for themselves in those moments. And we do create safety plans and follow-up plans. So we will refer people to more appropriate supports as needed. So we do drive in an unmarked vehicle to reduce stigma. And when I say plain clothes, our officers are in super plain clothes. One of our officers likes to wear tie-dye and stuff. So they try to be more well, tie-dye is not discreet, but they try to be more blending in. So it's not obvious that an officer is attending. So we will assist that person to make a safety plan and address any short or longer term needs and connect them to those supports that are needed. People that are seen by COAST tend to have serious mental health concerns at that moment and not really have the insight to know where to go or what's really going on. They are a bit higher risk factor, hence why we're going with an officer. And usually these people are disconnected from support. So our COAST team is to kind of come in and intervene with people that are very vulnerable and try to figure out how we can keep them stabilized in the moment. And we also get police occurrences from uniform officers that have attended live 911 calls where they think there is maybe a mental health component. So they'll give that occurrence to our officers who will hand it off to our crisis team, and we'll make a follow-up plan and introduce our services to people through that way. So we do really try to share our assessments with people's doctors or the current care team to help loop everyone in on what's going on to kind of make a more encompassing support. Okay, so our non-police team is 2 crisis support workers. So basically it's very similar to the COAST where we're doing the same kinds of assessments, but it's lower risk individuals. And these people really need some support in face-to-face. So our rapid response unit, our MCERT unit, so it's 3 units daily. So it's where a crisis worker responds to live 911 calls in a marked police cruiser. So there's 3 teams daily, 7 days a week, all year. So we have 1 unit that rides from 9 a.m. to 9 p.m. and then another 2 ride from 12 noon to 12 midnight. That doesn't necessarily mean they're available during those hours though, because they might be on calls, on break, and so forth. So we have just moved into a centralization where everyone starts out of the same division and they kind of just spread out. But before, people were in certain divisions in throughout Peel region. And so these crisis workers wear a vest that does say crisis worker, and they have a police radio with them. So it's fully integrated into 911 calls. So we have our MCERT officers. So they're basically based out of a division, but now all just respond regionally. And they, like I said before, they are trained in mental health, crisis intervention, and de-escalation. They had to apply for the position. And so they have a vested interest in mental health. Okay, so our CCERT team, which is going to be coming soon, is going to be 2 clinicians who will be dispatched to low risk, low priority 911 calls. So it's another way for a non-police response to a possible mental health call. Like I was saying, some people might not know how to call a crisis line or who to call. And so I know I even grew up in Peel region. I didn't know our local crisis line number. So if I was in a crisis, I might have called 911 too. So it's a way to reach that community. So it's very low risk people, and that might benefit from having mental health workers attend. And so they'll start from a police division and use a vehicle that's not even a police vehicle. It'll be like a civilian vehicle that's retrofitted with the police radio and their computer system. And so we are partnered with Punjabi Community Health Services and Roots specifically for this launch to create more of a culturally competent service. And so they are helping us staff so we can reach people. Okay. So what we do after all of these interventions is a lot of follow-ups and support. So once we've assessed someone and we believe that they're safe to remain where they are, we will follow up and complete the community referrals as appropriate. We do strive to really figure out what's their preferred service and really connect them with that service. So nowhere's out of bounds really that we won't try to refer someone. If appropriate, we do encourage people to make their own referrals so they're not, so they have a little bit more control, but we really will help if someone can't do it. And so we will phone someone or revisit as needed. So our visits aren't continuous. So usually it's a one-stop and then connection, unless there's a major change in their presentation. So we might have visited someone and 2 weeks later, they're even in a worse position with their mental health and really deteriorating to the point where now there's more risk. We would probably want to revisit that person. Okay, and then so how to get in touch with us. So anyone can call our number, so that there's our number, and we're option number 3. Option 1 and 2 are Every Mind, so that's for youth. We've centralized the one number, so it's easier, and even if you click the wrong extension, you will be rerouted to the right team. Okay, or for community partners, a crisis alert can be faxed to our fax number for crisis. That can be found on the CMHA Peel Dufferin website. And we do follow up on police occurrences that involve mental health and addiction components. So if you did call 911 for one of your clients, you can always let our crisis line know and say, I had to call on this date and this is our client's name. I think you guys might need to follow up, and then we can obtain that police occurrence. Okay, and so we'll save questions.
Thank you so much, Laura. That was very comprehensive and really outlined clearly the different pathways. So I'm just to encourage everyone to ask questions in the chat box, and we'll be sure to address them at the end. So Laura, I think you're still sharing your screen maybe. And in the meantime, I'll introduce our next speakers. So we have Erin Smith from CMHA Halton. She's a crisis intervention specialist in the COAST program at CMHA Halton Region Branch. Her previous roles included being the primary counselor for the Brampton Drug Treatment Court, a case manager in a supportive housing program, and a counselor in withdrawal management. Erin was previously a contributing member of the Association of Justice and Treatment Planning with Honorable Justice Barnes. And with her, we've been working closely with Jennifer Vanethu, who is an intake worker with CMHA Halton and has worked in this position for 5 years. And prior to this, she worked in the crisis programs, COAST and Safe Beds, and has been with the organization for 10 years. So Jennifer and Erin, welcome, and thanks so much for your presentation.
Thank you for having us. All right, I have multiple screens here, so I'm primarily based at home, so you'll see me looking at different screens. I promise I'm engaging with you. So we are CMHA Halton, very similar. It looks like we're continuing right from Laura, same slides, everything. Very similar programs, however, different programs as well. Not only, Erin will cover the crisis, I did add some of our other programs in here as well, because you can directly access a lot of these programs through myself. I will include my email address here, and again, anybody can email me directly, and I can sort out if a referral is needed, if we can connect right away. So more than welcome to send it right to me. All right, so who do we help? People 16 years and over who live in Halton, so Oakville, Burlington, Milton, Acton, and Georgetown. We do, for specific programs that we do go into Peel and part of Etobicoke. That's with our crisis outreach program. Erin's going to talk about that. There is no cost to any of our supports. We have multiple languages within CMHA. We are actually improving and trying to reach out to everybody that works with us to see exactly languages and cultures that we identify with, so we can better support. It will be a quality improvement project that we're working on. Coming soon. We're currently going through accreditation right now, so that's consuming majority of our time. So we have crisis service, case management services, walk-in counseling, shelter support, and family support. So Erin's going to take over.
Thanks, Jen, and good morning, everyone. I do apologize. This is very similar to some of the things that Laura previously talked about, but it's just important that we also talk about how it's available in our region. So the number one program I want to talk about is COAST, so our Crisis Outreach and Support Team. Like Jen had mentioned previously, it is a 16+ program. So for individuals living in Halton region, we do redirect to Kids Help Phone or the ROC, so the Reach Out Center for Kids, for individuals who are younger than 16. This is a 24/7 telephone support program. Anyone can call in who is in a crisis. It's very important to know that this is not a counseling service. This is strictly for individuals who are experiencing a mental health crisis. We are also not an emergency service. So for emergency services, we do redirect to 911, unlike CMHA Peel Different. The MERT team and the rapid response team is actually through Halton Regional Police. However, we do have our COAST mobile team. So that is the team I am a part of. I am a crisis intervention specialist. So that team consists of me and a plainclothes officer. The officer, even though they are wearing plainclothes, they still have to wear their vest and their belt, which contains a gun and a taser for safety concerns. Like Laura explained, the purpose of that collaboration is the mental status exam performed by the mental health worker. However, social workers do not have the grounds to apprehend under the Mental Health Act, and therefore we work alongside the police officers. We also have the opportunity to have service providers send in COAST alerts. So that can be found on our website under referral forms. Those can come from hospital workers. Those can come from other agencies. People who utilize COAST alerts are individuals who feel like their client may need support over the weekend and they're unable to provide that, or even hospitals who are discharging individuals and believe that telephone support would be a good option for their client. The next program is our COP program, so our Crisis Outreach Program. This is a short-term crisis management program. So it's approximately 3 to 4 weeks in length. This is to stabilize individuals who it might not be appropriate to consistently be calling our crisis line. They need more stabilization with a consistent worker. So we would connect them with this program internally. Again, this specific referral form can be found on our website. This program will never have a wait list. So we try to connect individuals within 24 to 48 hours. And hopefully the program will connect them with all the resources they need, which can include doctors, housing, and any other supports in the community we think would be beneficial.
I just want to jump in here. So we have another program. It's called our Community Concurrent Disorders Program. It's another crisis program. However, that's in Peel. And so it's the same program. However, you have to have addictions to be for that referral. I didn't have a slide for it, so I just needed to throw it. Thanks, Eric.
No problem. We also have what's called our Lighthouse Shelter. So this is a shelter previously for both male and female and non-binary. This is now a strictly male shelter. So individuals can go there and have mental health support on site. They stay there. And again, they can have short-term transitional case management if they need it. Our next one is our emergency housing. So we work collaboratively and in partnership with Wesley Halton Housing and the region of Halton to help individuals who need maybe support with housing or a shelter for family. So this is, it includes everyone. It's a broad spectrum. Again, crisis intervention support is available on site and who are residing in the program. Our services include crisis planning, stabilization, symptom management, relapse prevention, life skill building, and connection to other community resources. And I think the last one I'm going to talk about is Safe Beds, which Peel also has. So Safe Beds is a 24/7 community-based service for adults 16 plus who are experiencing a mental health and or addiction crisis. These referrals, unfortunately, do have to go through Halton Regional Police. They're the individuals who do make that referral. And Safe Beds is a person-centered collaborative approach. And again, it helps to stabilize those individuals who are experiencing a mental health crisis.
Awesome. Thank you. I'm just going to whip through our other programs. We have case management services. Our case management services are short-term. We're considered transitional for up to 3 months. And again, our case management services just cover Halton. As Laura was saying, Mississauga has a little bit of a gap for case management. We have the Community Concurrent Disorders Program case management in there, and we can provide case management for up to 3 months for people that are struggling with addictions and mental health. So just addictions and mental, like concurrent, or just addictions. So sometimes we try and finagle and finesse that to try and work with the Mississauga client to try and get them into case management services. A lot of the times, if the client is willing to travel to Halton, I'll still take the referral because then I can base it in Halton. So we're trying to fill that gap. We have the dual diagnosis case management program. This is Halton strictly, and this is longer term. They say up to 6 months. However, I see it can go longer, up to a year. And this is for developmental and mental health or addictions. There doesn't need to be any diagnoses for our programs, as well as the dual diagnosis program. We have justice service programs. We have court support. So with the court support, the actual court has to be within, sorry, the charges have to be within Halton. However, the clients can be living anywhere. Release from custody, they're usually working out of the institutions right now, and we get a lot of referrals for them from probation and the institutions themselves. So for these programs, for justice service, it can be a quick email to myself and I can send the information right off to the court support workers. We also have walk-in counseling. It is not walk-in counseling, it is call-in counseling right now. And this is open to everybody. I don't think they have a restriction in area with, they take any calls. It is, you call, you leave a voice message and somebody calls you back within 48 hours, and you have a full session with a brief solution focused counselor. You can call multiple times. If it becomes, it's not long-term counseling, you will not receive the same counselor all the time. They do their best, but if it's ongoing, they're going to try and support you to find other resources because it is not ongoing. We have recently picked up the Ontario Structured Psychotherapy Program as well. So we have 2 full-time clinicians right now that are working OSP specifically. I don't know, I think OneLink is doing referrals for that, and it's a slow launch. So I don't think they've really announced it across the regions yet, who's covering the OSP structured therapy. And that's it. But I'm going to put in the chat my email. So if anybody has any questions, they can absolutely email me directly and I can do my best to find whatever you need.
Fantastic. Wow. I'm so impressed how you you all ran through all the different streams of programming and crisis supports. So thank you so much, Jennifer and Aaron as well. Just wanting to open up the space now for questions. It was really comprehensive, but I'm sure there's questions out there. I'm wondering, Laura, Jennifer, Aaron, if you might have lists of languages that we could email out to the group of languages that are available through your services. That way, you know, just knowing that there's influxes of Ukrainian speakers and Dari and Pashto speakers through the Afghan initiative, it might just be helpful to know if you have that on hand or if that's something that we might need to just shore up and partner on. So any questions from the group? Now's a great time. You can raise your hand. You can come on camera and raise your hand or ask your question in the chat box. I'll start with Kathy.
Hi, thank you guys so much for the presentation. So much information. It's fantastic. I'm looking forward to sharing it with my team that couldn't attend today. I think my question is really around making appropriate referrals. So how would you recommend us best? We have a client, or if we have a situation with any of our team that's working with clients that has identified that they need some support. What is the best way for us to make a connection to all of the resources? Because we do have clients that are not just from Caledon. We have clients from all over. So I don't know if anyone can help me with that one.
So I usually recommend, like, if like there's questions, just connect with the crisis team, right? Like calling us. So we usually help with systems navigation, or even just discuss our services. So usually it's the most organic way to get the most information that probably be helpful is over the phone, because usually you get a crisis alert too, right? It's a finite space, so we might not grasp everything that's happening in that moment.
So staff to call the line, but ask to speak to someone about a specific client.
So if you just call the crisis line, it comes directly to our crisis team. So a crisis worker would answer, and then you can speak to any crisis worker.
Thank you.
Kathy, you can, if you have clients that are in parts of Peel or Halton, you can email me or call me directly. I'm information referral / intake / presentation / every referral comes across my desk. So I'm very open to helping navigate that for anybody.
Okay, and that's for which area? Sorry, Peel.
So we do Halton, we do Oakville, Burlington, parts of Peel, parts of Etobicoke, as well as Georgetown, Acton, and Milton.
Okay. Gotcha.
Can we talk a little bit about the Peel? I know we touched on it a little bit. There seems to be a bit of a gap in Mississauga. Can we talk a little bit about that and before we go to the next question?
So I know that I can speak on our side that we have partial funding for Peel, but it's addictions based. So we have case management services and crisis services, not that we don't cover their crisis line for Mississauga. Ours is our crisis outreach. So we have short-term case management and other crisis case managers. So they either have to be concurrent, so mental health and or addictions, or just addictions. But like I said, if people need case management, and I'm only saying this to you, so don't advertise it to everybody else. If they're willing to travel to Halton, I can sometimes get them on the Halton wait list. Or if you have a client that doesn't have major addictions, maybe drinks too much coffee or, smoking, we can sometimes use that for concurrent as well. So if you have a client that you're struggling, again, just reach out to myself and we can kind of navigate if I can take them. Yeah.
Thanks so much.
Laura, I don't know.
Yeah, I'll elaborate. So we have some regional programs versus LIN-based programs. So our counseling, case management, all of those are LIN-based, which don't include Mississauga. Crisis, our outreach, which is for people that are homeless or marginally housed, and our justice team are all regionally based programs, along with we have a peer support program. So we have some programs that will bridge into Mississauga. Usually when we do get a client that is in Mississauga and lives there and needs case management and counseling supports, we help facilitate a referral to One Link, which is their intake there. So we do help facilitate and give information of different walk-in programs that would be available in their regions too, such as like Catholic Family Services Appeal, Catholic Family Services, Family Service Appeal, so forth. So it's always helpful just to, even if you just talk to any of the crisis workers, we're well versed in navigating this awkwardness. So we're always able to help and kind of give you a better idea what might help.
Perfect. Thank you so much. I'll move to Hala's question. Go ahead, Hala.
Yeah, thank you. So I was wondering whether the volunteers play a role in the Canadian mental health. So do you accept volunteering, for example, to cover the gap for languages? And
So
Mhm.
we at CMHA Halton, we currently don't have volunteers, but that's only because of the capacity we have. We don't have a proper volunteer. I don't even know what I'm trying. We just don't have the capacity to implement the volunteer program at this time. I do see it coming in the future, but currently not right now.
Okay, thank you, Jennifer. And well, how about Peel, like Laura?
So no, so we typically don't take volunteers, especially for the crisis program stuff, because it's so we have to go through special clearances, but also too it's high level, and so that's why all of us have to be registered health professionals, because we are making some hard clinical decisions about someone's treatment sometimes.
Yeah.
Yeah, and so typically,
Actually, I was referring to the language because I mentioned Jennifer. I believe that she mentioned that the languages. They're not like the interpreters are not that wide like Mississauga or Peel, right?
So,
did I get it right, Jennifer?
We don't have a large base of direct service staff that speak different languages. That's something we're working on right now, but we have interpreter services across every one of our programs. Yeah.
Thank you. Okay. Thank you, Laura. Thank you, Jennifer. Thank you.
And the same for Peel. So we have partnerships with interpretation services, and we're partnered with Punjabi Community Health Services to help with a lot of language gaps.
Thank you so much.
Thanks, Hala, for the question. Shreya?
Thanks, Jessica. There was a question in the chat which I wanted to bring up. So this is for Doris. She mentioned that the crisis support workers also train the settlement staff. So there was a question asking how can we register for those trainings?
Okay, we offer those trainings each one in our organization. However, some of us have been trained in compassion fatigue or empathy strain as well. So we started to have this training, and which is an amazing training now. We're doing in Halton, and I know other people are doing it in Peel region, right? So at Halton, we already did with HMC. We are in the second part of this training, and we're going to do it very soon with the rest of our newcomers organizations in Halton. So that it will be one that I will recommend, and that you ask to your crisis worker to provide a training in mental health, and she will be really, really happy. Or maybe we can do it together, and that's an excellent idea. But that's what we do internally in each organization. We provide that.
I have another question for Doris. You mentioned that there are crisis workers, the Swiss workers in the school. So how does this work? Like every school is allotted one Swiss worker individually?
Yes.
Okay.
Yeah, we have settlement workers in the schools, in the public board, and in the Catholic board. And what they do is they connect with the families, and they work with the newcomer children as well in general, and refugee children. It doesn't matter the status, but they work with all the immigrants in the schools. And if they identified when they are doing the intake of those families for their programs, if they have identified something, maybe that person or that mother or this family in particular needs some support, they refer them to us. Okay, exactly, they refer them. If they belong, let's say, to HMC, they will refer that client to HMC, to the crisis worker in HMC, or as I told you, the process in our way, if that person speaks Spanish, let's say in my case, they will refer that case to me. So we will work in a team way, right? It's not that it's the client of HMC or the Center for Skills Development in Halton, and then no one can see it. Only, no, we support our efforts together. It's been a very beautiful way to work in a team effort.
Thanks so much, Doris. Really great to hear. And we have, Shreya is organizing some other sessions to raise the profile of some of the trauma-informed training that is going on in Peel and Halton. So
we need that. We need that training.
Yeah, yeah. So just for everyone's awareness, there will be we'll be sure to share on that. And Shreya, if you want to put in our chat box how to sign up for our newsletter, then people can stay apprised.
Excellent.
Yeah, Atia.
Thank you for so much informative presentations, and I am a comparatively new hire, so I'm learning a lot through these presentations. That's why I'm eager to join every opportunity to attend. So my question might sound, I don't know, coming from a novice or someone who is not very much experienced. But I was just looking for, like, are there any general identifiers or red flags that should, readily remind us to refer anyone to who might need mental health? I'm just looking for something that kind of stands out as a new person, because I'm not very well versed with it. So I was just wondering if, I might not overlook something. Could you guys hear me?
Yeah. So basically, right, we look for any changes in their presentation, right? So we rely a lot on family or people that really know the person, right? Case managers. You'll notice over time if someone's, right, they're not cleaning themselves like they would, or their demeanor is really changed, then it might be a time to kind of address, is there something else going on? So we typically look for those changes. They can be small or big. It could be someone all of a sudden showing up a little bit late to appointments when they were always on time before, right? Is something going on? It might be, you might figure out, hey, it might be because they have concerns around childcare and the time's not working, but they might be afraid to ask. So it might be something simple like that, or it might be someone is experiencing a hard time sleeping, so they're having trouble getting up in the morning.
Thanks so much, Laura.
I just wanted to throw out there, we had some, when I was at CMHA and I was doing a little bit of counseling, not really counseling, we actually had somebody, a cultural interpreter from HMC that was supporting us, and I found it absolutely amazing. So not only was it language interpretation, they were interpreting for me culture. So whether it was appropriate for me to ask this question or to say this, and I found it amazing. So if you're aware of the culture, and if it's appropriate to just ask, how are you feeling, or how are you doing? Are you struggling with anything? Mm-hmm. Being direct, if appropriate, is really the best way to ask if anybody's struggling with mental health. Yeah.
I wanted to add something that Jennifer is telling is really, really important. What we do in one of the trainings that I provide to my settlement workers, colleagues, that was like 3 or 4 questions that they can do to their clients when they are doing the intake. How you're feeling? Is there something that you really need support with at this time? If you don't have the answer at this time, we have support for you in case you need it. You just need to talk with us. Just leave the information open, because sometimes people don't want to say they need something, or people, they don't want to express how they are feeling at the moment. But then also the teachers in the school, they start to notice things. So they are the ones. That's why we said we are the ears, we are the eyes, and we are the heart of these families, because we notice. We all have an idea about mental health, and working with people, we know when something is not right? So that's the way we refer our clients as well.
Super, thanks so much. Daniela?
Yes, thank you. I have a question regarding to referrals. We are not allowed to share the personal information from our clients. So how we have to proceed if we think that the client needs assistance? can they call by themselves? I think this question is for Jennifer. Or we have to, I don't know, talk with someone and someone else has to refer them. To get this service, they really need the referral. They can contact you by themselves. This is my question.
They can self-refer. They can call the agency directly and self-refer to any of our
Okay.
Programs. Yeah.
Okay, thank you.
No problem.
I also want to add something, Daniela. What we do in our settlement sets of services is that if we are with the client and we know that the client has not enough, for example, he doesn't or she doesn't feel enough confident to call and self-refer, we do for them. But we always have the consent to share the information. We ask for them to sign the consent before share their information. So that's what we do, because sometimes when you're feeling really down, you have no energy to look for support yourself. So we're there.
Thank you very much. Thank you. Thank you.
Thank you.
These are great questions. So thank you for raising them. Any other thoughts? I have a question, I guess, for all those who were speaking, if you don't mind commenting on any changes you've seen, you know, in the past, you know, 6 months to a year. Have you seen, like, we're slowly coming out of the pandemic, have you seen any differences or changes in who's coming or asking for services?
I've seen an intake or an increase on the front end of youth, lots and lots and lots of youth seeking services or their parents. I think Erin would see more of that, crisis calls from parents seeking support for their young ones. Lots of anxiety, eating disorders have come from the pandemic, I believe. Erin, can you speak to that?
Yeah, we were actually talking about this yesterday. Within Coast, we were seeing on average about, before the pandemic, we would say the average age range was 40 plus, so 40 to about 65. And yesterday we were talking about how many parents are calling in for maybe 16 to 25, how many, you know, young people in their 20s are calling in on themselves. Lots of discussion around social anxiety, lots of discussion around depression, starting to understand the impacts of doing university online. A lot of individuals calling because they had to drop out, that platform didn't work for them. So we're really seeing a different age group utilizing these services and reaching out, just accessing case management and mood disorders. And like Jen said, eating disorders are coming into play. So yeah, I would say the age range and the intensity of the calls we're also receiving for Coast Mobile, they're much more escalated than previously.
Thank you for sharing.
Yeah, it's very similar for Peel friends. So our age range, we've seen an increase between 25 and 35-year-olds calling. And so our rapid response team through 911 does attend 16 and under. And so we've seen an increase in calls for youth through 911 and calls in general to our crisis line. During the peak of the pandemic, our call volume had increased by 40%.
That's incredible. Doris, do you have anything else to add?
Yeah, in my case, as I work with newcomers, families, with immigrants in general, I have seen especially during these 2 years, that people were more open to look for support. They didn't have this prejudice about talking with a mental health worker about their issues and acknowledge they have an issue or a situation that they need support. So I like that. I think that was something that opened up a little bit their mind, because we're educating them and trying to decrease the prejudice and the taboos and the labels related with mental health. So I have more open up, and more clients because the situation forced them to look for support. And we have more refugees, refugee claimants looking for support, because it's just natural that this was going to happen. And it's been like, with support, our service is supposed to be to permanent resident, right? We cannot leave anyone behind just because they don't have this convention refugee or permanent resident status. So they were the most at-risk people that we have, more prevalent population, and that's what I can say.
Okay, thank you so much. And yeah, I can agree that there are some barriers to services sometimes, but it's great to hear that you're able to provide them nonetheless.
Yeah.
Okay, I see there's two last questions in our 2 minutes. So Shreya, go ahead.
So I have two questions, one for Laura and one for Jennifer. I'll go with Laura first. So Laura mentioned quite a few areas where the CMHA Peel and Halton services are provided. What if there is a caller calling from Toronto during the 24 to the helpline 24/7 crisis helpline? How are they served? Are they referred? Like, how does it happen? So this is for Laura. And for Jennifer, the emergency housing, is it through referrals only, or it could be walk-ins, because there are sometimes women who are facing that domestic violence and need immediate shelter? And also if there is a maximum time period where they can be housed in those emergency housing.
So I'll pause there and I'll ask Amtul to ask your question, and then maybe we'll have to answer those questions by email depending on time. Okay, go ahead, Amtul.
Thank you so much, Jessica. My question is for Jennifer, Laura, or Erin, whoever wants to answer. So as you were mentioning that you received a number of youth clients, and similarly, I'm also, I came across some clients who need some support for their kids, like 16 plus. But the thing is, the youth is not ready to talk to someone. So what's the way? I mean, the parents, they are going through a lot of frustration, and they are very worried about their kids. But there is no way that they can convince their kids. We provide them the information, and as Doris said, that you can just leave that information with the person if they want to. But in most cases, the kids, they don't use that information. So in that case, what's your best idea or opinion? How can we convince the kids, or what's the way to for the children if they can contact some professionals? You know what I mean? I don't know whether I explained it properly or not.
So since Shreya, your questions were more operational, we'll address those by email, and I'll just give a moment for the speakers to answer Amtul's. And just to let everyone know, we're also going to be speaking with EveryMind to see if we can set up a session such as this regarding youth, since they are serving that age bracket. So I'll turn it to the speakers now.
So I can say, I was going to say EveryMind is probably the best. So we have amalgamated our number. So it's one crisis number. So if a parent calls and accidentally gets to our service and we feel like EveryMind would be more appropriate, we can internally transfer that call. We also do referrals to EveryMind. So there's 3 options when you call the crisis line. I believe the first is if you're a parent calling for a youth and you need support in supporting your youth. Then 2 is for youth, and then 3 is for 16 and up, and then comes to my crisis line. The other 2 go to EveryMind. So the option is a parent can always call EveryMind's crisis line number, and they do provide a lot of supports to parents. I can say for CMHA Peel Dufferin, we do have a family support worker. So we have a specific program for family members that are struggling in supporting a loved one with mental health. And even as the crisis team, we do a lot of that navigations with the families and talking about what are the limitations that we have in engaging with people, their rights, but also what we can do to support the family members.
I get I get lots of these calls from parents that are trying to get their children into services. And what I found successful is if it's not a crisis, then when I get these calls, I try and develop some sort of relationship with the parents so they can go back to the child and say, hey, I spoke with Jen at CMHA, she's willing to text with you, or trying to, so you can put a name to where the youth is calling works out better. Or we also have the walk-in counseling where the parents can call in and get tips and support on how to work with their child. But we've been successful connecting youth when there's that personal connection. I hope I answered your question.
Yes, absolutely. Thank you so much, Jennifer.
No problem.
Good.
Well, if we had more time, I'm sure there'd be more discussion, but I really appreciate everyone joining in and all of the discussion that did happen today and the wonderful presentations. Thank you so much, Doris, Laura, Jennifer, Aaron, for the time and effort you put into presenting. And we'll be sure to share out by email from there and with some follow-up on some of those last questions. Thank you everyone for joining and hope you have all a great day and have some time for your own mental health promotion too. Take care.
Thank you so much.
Thank you.
you.
Thank you. Bye.
Bye.